Okay, today we are going to see RH negative in OPS. Okay, see, first if a mother is coming to the OPD, first main culprit is RH negative mother reacts with any positive blood. Okay, so first if mother is coming, if RH positive, it is O positive, B positive, no problem. But O negative, A negative, RH negative mother means then first you have to check the father blood group. Okay, first was 12 weeks booking visit. 12 weeks means 4 months, right? 3 months. So then you have to check the father's blood group. That is indirect home test. Through indirect home test, and if it is negative, father's blood group, and also for indirect home test in mothers, negative means there is no antibody. Okay, so no antibody. Then you have to assess the other risk. If she is a priming or no history of transfusion, or if she is multi or history of transfusion. So if she is a priming and no history of transfusion means then you have to repeat the ICT at 28 weeks. Okay, then you have to give anti-D at 28. You know that, right? ICD is negative, so no antibody. So we have to prevent further formation of antibody. So to prevent the further formation, we are injecting antibody so that the antibody could not be formed inside it. Okay, so we're giving anti-D at 28 weeks, antepartum anti-D. Okay, 300 microgram. Next, she is delivering at 40 weeks. Then you have to check the baby's blood group. If the baby is RH positive and Coombs test is negative, okay, then you have to give anti-D within 72 hours of delivery. We should give anti-D only to mother to prevent the formation of body's antibodies. Okay, inside in vitro antibodies. To prevent the formation of in vivo antibodies, you have to give anti-D from outside. So I am giving 2 times, one at 28 weeks, one after delivery within 72 hours. If the Coombs test is negative, there is no antibodies are formed in vivo alone, you are giving anti-D outside. Then next, for multi. So you are seeing at 12 weeks, that is the Coombs test is negative, no antibodies are formed. And then you are assessing the multi or history of transfusions. If she is a multi and so many histories of transfusions are present, then you have to ICT, that is repeat the ICT every month starting from 12 weeks, that is 3 months, and after 20 weeks up to from 12 weeks up to 20 weeks you have to repeat per month. 12 weeks means 5 months, right? So 3 months, 4 months, 5 months. Then after 20 weeks, do it bi-weekly till 28 weeks. 28 weeks means 7 months, right? So 6 months, 7 months, bi-weekly. Okay, so 1 month twice. Then if ICT remains negative, then up to 28 weeks you are seeing it, up to 7 months you are seeing. So in 7 months, if the ICT remains negative, then give anti-D. Okay, and also like the same delivery at 40 weeks. If she's Coombs test is negative, then you can give anti-D within 72 hours. Okay, understood, right? For multi, so for priming or no history of transfusion, for multi, you have to check at 3 times, 12 week, 28 week, then after birth. Okay, but should give anti-D only 2 times, at 28 weeks and after birth. Okay, sorry, after delivery. Okay, then if ICT is positive, then what will you do? If you are coming to know that if the ICT is positive, then we have to repeat the ICT titer every 4 weeks, every month. Okay, every 4 weeks. So the critical titer is 1 in 16. That means if the antibodies are more than 10 international unit per liter, titer is critical titer value 1 in 16, 1 to 16. Okay, so you have to repeat the ICT titer every month. Once you reach the critical titer, then you have to do fetal MCA Doppler. MCA means middle cerebral artery Doppler. If there we have to measure peak systolic velocity. Okay, there you have to measure peak systolic velocity. Why you are measuring peak systolic velocity? Systolic velocity, the flow of blood. If the flow of blood is high, means there is anemia. If it is okay, means it's normal. So if there is a peak systolic velocity, PSV is more than 1.5 millimoles, then that is fetal anemia. Okay. If less than 1.5 is no that at that particular time there is no anemia. So repeat the MC Doppler every 1 to 2 weeks. Okay, we shall assume to be 2 weeks. Okay, so 2 weeks, then divided by 37 weeks. If there is an anemia, then you have to check umbilical artery chordosynthesis. See, actually we do first chorionic nuclei sampling, then amniocentesis, then chordosynthesis for prenatal diagnosis like anomaly. Okay, for chorionic nuclei sampling we do at 10 to 13 weeks. For amniocentesis we'll do at like 13 to 15 weeks, and for chordosynthesis it is 15 to 20 weeks. Like last step is the chordosynthesis, umbilical cord. Okay, so here we are doing the chordosynthesis, this is umbilical artery chordosynthesis, and to check the again the anemia only, but through hematocrit. So if the hematocrit is less than 30 or more than 30, so if it is less than 30, hematocrit is 30 means what's mean, that is RBC cells are slow, right? So if it is less than 30, then intrauterine blood transfusion, and you have to deliver by 35 weeks. If it is more than 30%, okay, then repeat the chordosynthesis after 1 week. 1 week, 1 week, repeat the chordosynthesis. When it is become more than, less than 30%, and then you have to give the transfusion, blood transfusion, and deliver within 35 weeks. Up to fetal maturity, like climate maturity, 35 weeks, be enough. Again, we don't need. Okay. We have studied if it is no ICD means IC negative and IC positive, right? ICD positive, what? Okay, shall we recall? If ICD is positive, then what we can do? We have to see the titer. Okay, the critical titer value is 1 is 16. So we have to check the titer every month, monthly once. Monthly once is enough. Once it is achieved 1 is 16, then we have to see the brain, fetal brain, that is middle cerebral artery Doppler. There we are seeing the systolic velocity of the blood, peak systolic velocity. If it is more than 1.5 norm means there is anemia. If it is less than 1.5 norm means there is no anemia. So you have to check like twice a month or by 2 weeks. Like you have to check, you can deliver at 37 weeks. But if it is peak systolic velocity is high, then you have to check how much anemia is there. So you have to do chordosynthesis, umbilical artery chordosynthesis. There you are seeing hematocrit. If it is more than 30%, okay, then you have to see like 1 week, like that, and you have delivery. Okay, you are assessing. You kept there. Here, if it is hematocrit is less than 30%, means you have to do a blood transfusion, and you can deliver within 35 weeks. So therefore we are assessing now if it is hematocrit is more than 30%. Then also there if it is reduced means you can continue with transfusion and come to this. That's it. Okay, it's easy only. Okay, then some important points. So for RH immunizations we are giving anti-D injection, right? If it is less than 12 weeks means we are giving 50 microgram, more than 12 weeks means we are giving 300 microgram. Okay. All RH negative patients are routinely administered 30 microgram of anti-D at 28 weeks of gestation now. Okay. Next, for anti-D. So it is prepared from where? From the serum of RH negative males. We are giving 300 microgram, that is 1500 international units IM deltoid. Giving deltoid through IM injection. See, BCG also you are giving deltoid, but there is a subcutaneous, right? Here is a intramuscular injection. And some of the test RH negative we can do some test. Okay, for a fetal-maternal hemorrhage. For fetal-maternal hemorrhage we can do a test called clear Bedke test or acid elution test. Clear Bedke test or acid elution test. If 300 microgram of anti-D neutralize the 15 ml of fetal RBC or 30 ml of whole blood. We are giving 300 microgram of antibody, right? We will only neutralize 15 ml of fetal RBC or 30 ml of whole blood. Whole blood means 30 ml. Fetal RBCs means 15 ml. Okay. So, 10 microgram antibody will neutralize the 0.5 ml of fetal RBC or 1 ml. 1 ml of fetal maternal hemorrhage. So, for 1 ml of fetal maternal hemorrhage, 0.5 ml of fetal RBC, we should give 10 microgram. So 30 ml, 15 ml, 300 microgram. Understood? 1 ml, 0.5 ml of fetal RBC, we are giving 10 microgram. So 30 ml, 15 ml of fetal RBC, we are giving 300 microgram. So quantitative test, what is it for? Quantitative, already what's test? Test name? Clear Becky test. Clear, that is KLIEUHAR, or acid elution test. Then again some other tests there. The effect of RH isoimmunization in fetus. So what are the effects are there in RH isoimmunization in fetus? First, a congenital anemia of newborn. Yes, of course there is anemia of newborn. For anemia, if the RBCs are destroyed now, because isoimmunization process, right? Autoimmune hemolytic anemia like that. So excess gravidarum neonatal. Then liver and spleen RBCs are produced in vitro by a liver and spleen. So hepatosplenomegaly. See, the liver is not, spleen is not enlarged due to destruction, but because of RBC production. So liver, hepatosplenomegaly. So there's a severe anemia, cardiac failure, and anasarca, and immunohydrospitalis. Erythroblast, otherwise called as erythroblastosis fetalis. So there is an anemia for which the cardiac failure and whole body edema, that is anasarca. Okay. Next. So what are the findings we can see in USG? Ascites, pleural effusion, pericardial effusion, then skin edema, mainly the scalp edema. We can around the fetal head we can see a halo which is called as Buddha sign. Then placental size will be increased. Then hepatosplenomegaly. See, for big placenta, wherever there is a big placenta, there will be PAH, right? So the mother will be having pregnancy-induced hypertension. So we are having one syndrome called mirror syndrome. Like mother also edematous and fetus also edematous. Fetus edematous due to high dose, but mother edematous due to pregnancy-induced hypertension. Okay. Why behaves like this? Shall we see some questions? Anti-D prophylaxis will be given in all of the following conditions except where the conditions we can give anti-D except medical abortion for 63 days of pregnancy. Yes, medical abortion we can give. Amniocentesis at 16 weeks. Amniocentesis is done at 13 to 15. Okay, for 16 weeks. Okay. Yes, we can give. And manual removal of placenta. See, for manual removal of placenta also we can give, but where? Not for all, right? For manual removal of placenta we are giving. Yes. Sorry, we are. Yes, we can give for all. For all means if we are removing the placenta by manual means manual method. Okay, there we can give because there's a chance of fetal maternal hemorrhage, right? That means fetus blood may be mixed with mother's blood in that situations. Next, intrauterine transfusion at 28 weeks. Intrauterine transfusion. That means here the patient is already isoimmunized. Already the patient has antibodies, right? So then why should we give anti-D? So no need, right? This is the answer. Next, at 28 weeks of gestation, amniocentesis reveals some OD450 of 0.20, which is at the top of a third zone of the Lilly curve. The most appropriate management of such a cases. See, the Lilly's curve has like A, B. There will be zones like, okay? Mild anemia, moderate to severe anemia, like 3 zones A, B, C like that. If it is above, here can you see the curves? So if it is above means that is like severe anemia. So the most appropriate management of such a case: immediate delivery, repeat amniocentesis after 1 week, plasmapheresis, intrauterine transfusion. See, for plasmapheresis, no need. In either way, we are not doing plasmapheresis now. Repeat amniocentesis after 1 week. This is we can do in moderate cases like repeat amniocentesis after 1 week. Then immediate delivery is no need. We can try for intrauterine transfusion, right? So for severe anemia, that is the third zone of top of the relief curve, we are doing intrauterine transfusion. And the next, in non-immune hydrops, which is the following not seen. Non-immune hydrops. Skin edema is seen, large placenta is seen, ascites is present, cardiomegaly. This is not right. Pericardial effusion is here, not cardiomegaly. RH isoimmunization in pregnancy can cause all except isoimmunization. What are the things it cause? Antepartum hemorrhage, yes. Pregnancy-induced hypertension, yes. Postpartum hemorrhage, right. Oligohydramnias, no. Polyhydramnias. Why poly? Because there's a big placenta. There's a full edema, right? Again, 3 questions. 3 questions there. Anemia of fetus. Anemia of fetus in RH immunization can be estimated by anemia. Okay, how are you estimating this? Increased middle cellular artery blood flow, right? Chordocentesis. Through chordocentesis, we are seeing hematocrit now. So we are assessing, right? So yes, sinusoidal patterning cardiography, CTG. See, another one information. If a CTG shows a sinusoidal pattern, it is a fetal anemia. Okay, the UST of placenta. Can you see anything through UST of placenta? Yes, if there is a big placenta, there are multiple reasons. Not only this, right? So it's not. So it's answer. Next. This is the correct statement. Indirect womb test is performed in mother. Yes. See, for in a fetus now, we can do a direct womb test. That is, direct womb test means we are checking if like if antigen antibody reaction in fetal or disease, the antibodies are attached or not, like that. But for indirect womb test, we are checking in mother's blood whether the RH antibodies are present or not. So indirect womb test is always done in mother. Yes, right. In simple way, we can get it like that. Like direct womb test, we are assessing the RH antigen. Indirect womb test, we are assessing the RH antibody. So the RH antibody will be always present in fetus now. Like that we can keep. Okay. Next, methogen is withheld at the delivery of anterior shoulder. Why they are withholding methogen? Yes. For methogen, it should be we should not give in here RH immunization. MC artery peak systolic velocity is an accurate method to predict if anemia. Correct. Next, a 25-year-old G2P1L1 RH negative woman presented at 30 weeks gestation to the antenatal clinic. G2P1L1 RH negative woman with 30 weeks of gestation to AN clinic. The indirect womb test was found to be positive. At 30 weeks, the test is positive. What would be the next line management? See, already she's a gravid 2 and she's positive. So the first child may be positive. So the antibodies are formed at the time. Now she's positive. So we can't, if you are giving antigens, no use, right? See the options, anti-D to be given. No, why should I? Next, IC titers to be closely monitored at weekly interval. Maybe. Amniocentesis for estimation of bilirubin by release chart to be done. First, we can measure the titers, right? If it is increased, it achieved a critical data means then we can measure the mean systolic, like MCA. If it also increased means like chordocentesis. So direct straight away amniocentesis is not a cause. I think so. Next, baby is to be delivered as soon as possible. Why? First, we have to do IC titer. So IC titer is the correct option. What's the next line management, right? So IC titer. Okay, we have finished the RH isoimmunization. It's nice, na? Biophysical profile. This is also easy topic only. So we can please see. For methods of assessing the fetal well-being, we have antepartum, intrapartum, and postpartum. Okay, for antepartum, like stress test, non-stress test. For non-stress test, there shouldn't be any stress. That means the patient, that is the mother, should not be in labor. Okay, so for antepartum, we can do a non-stress test and biophysical profile. Then vibroacoustic stimulation test, contraction stress test, oxytocin challenge test, fetal kick count, color Doppler USG. These are known. For intrapartum, we are doing CTG, cardiotogography. Same, that is that CTG. We are giving a name non-stress test in antepartum, and for intrapartum, we are giving the name CTG. Okay, see, that's no need. Okay, we are most commonly used is the fetal kick count. So now see the fetal movement count. It is done after 32 to 34 weeks. Normally the count should be 30 count. Daily fetal count post meal. So post meal we have to measure the fetal count. 10 movements in 12 hours. 10 counts in 12 hours is normal. How we should measure means 1 hour post breakfast, 1 hour post lunch, 1 hour post dinner. So in each hour 3 to 4. Then total approximately 10 means okay, right? So biophysical profile for the mnemonic band motto. B, breathing. A, amniotic fluid. N, non-stress. Motto, movement. Tone. Okay, for breathing, that means see this biophysical profile, also called Manning's rule. This all should be done within 30 minutes. So for breathing, one episode, one or more than one episode, rhythmic breathing. Rhythmic breathing means one inspiration, one expiration. Okay, that's enough. Here saying is lasting more than 30 seconds. Okay, limit 30 seconds. Then amniotic fluid volume, you know, right? A single vertical pocket should be more than 2 centimeter. Normal value 2 to 8 centimeter, right? 2 to 8 centimeter. This amniotic fluid index, right? Okay, next N, but here say amniotic fluid volume. Okay, next N, non-stress test is an acceleration. CTG, now we are seeing acceleration. So more than or equal to 2 accelerations of more than or equal to 15 beats lasting for 15 seconds in 20 to 40 minutes. It's a reactive NSD. More than or equal to 2 accelerations with more than or equal to 15 beats variation lasting for 15 seconds in 20 to 40 minutes. Okay, that's a non-stress test. And then for movement, what we can say for movement is a body movements, right? Any limb movements more than 3, more than or equal to 3. Tone means one episode of extension of a fetal extremity with a return to flexion or opening or closing of a hand within 30 minutes. See, one extension followed by flexion or opening or closing of hands within 30 minutes, equal to or more than 1. So we can assess, right? These are first 2 scores, total 10. Okay, so band motor. B, breathing. A simple breathing, inspiration, expiration lasting for 30 seconds. A, amniotic fluid volume, single vertical pocket should be more than 2 centimeter. A, non-stress test, that is more than or equal to 2 accelerations, right? With 15 beats variation is lasting for 15 seconds in the duration, in the time 20 to 40 minutes. Then for a movements, so like extension followed by flexion or opening or closing of hands within 30 minutes. Then tone, sorry, I said wrong, right? Movements means any movement. These are movement, right? So any 3 discrete movements. Sorry, tone only this. Sorry. Okay. Modify biophysical profile means AFI, amniotic fluid index and NSD. So biophysical profile, total value 10. We are doing 2, 4, 6, 8. 2 means certain asphyxia, 4 chronic asphyxia, 6 chronic asphyxia, 8, 10 no fetal asphyxia. So if it is a certain asphyxia means we have to do a test for 2 hours. Then if the score is persistently less than or equal to 4 means deliver. If chronic asphyxia means more than 36 weeks means deliver. If less than 36 means repeat testing for 4 to 6 hours. Okay. For 8 10 the weekly interval. Repeat the testing at weekly interval. This is like somewhat interpretation is somewhat difficult, right? See, first 8 to 10. Next 6 4 0 to 2. So here no asphyxia. So we are doing weekly interval repeat test. Here 6. If it is more than 36 weeks, you can deliver. No problem. In the same case, the 4 6 2 are chronic asphyxia. But if it is less than 36 weeks, you have to repeat the test for 4 to 6 hours. Here repeating weekly, here repeating 4 to 6 hours. Then last 0 to 2 is certain asphyxia. So there we have to measure for 2 hours. The score is again less than 4 deliver. For testing weekly 4 to 6 hours, 2 hours. Okay. Next, oxytocin challenge test for assessing fetal well-being is contraindicated in all except. So where and all contraindicated? No need. Okay, this is an outdated test. I won't ask. Like we can leave it. NST, reactive NST. Already you studied now. Baseline fetal heart rate 110 to 160. Baseline variability more than 5 beats per minute. 2 or more acceleration. We studied that. No deceleration. See, already for sinusoidal pattern, we studied the fetal anemia, right? So sinusoidal pattern is fetal anemia. You can see here. This is sinusoidal pattern. This is fetal anemia and fetal hypoxia. And we have like 3 variations in NST. Early deceleration, like acceleration is okay, but deceleration is false, right? So early deceleration, late deceleration, and variable deceleration. So what is early deceleration means? Like if it's a this is graph, right? So here we have accelerations. Here we are measuring uterine contractions. So for first, here if this here first uterine contraction, the acceleration this also like this acceleration decelerations are fetal heart rate. This is uterine contraction, this is fetal heart rate. So the fetal heart rate, this is decreasing, right? This is deceleration. When it is like when the contraction is starting, at that time the deceleration also starting, it also coincides with the contraction, right? So this is a early deceleration. But when the contraction is ending, that time alone, that time the deceleration is starting now. That is a late deceleration. Understood? Variable means the uterine contraction and the deceleration, there is no connection. It will do anytime independent. Okay, that is variable deceleration. So for early deceleration, here contraction, there the heart rate is going down. So what condition? Is a fetal head compression. So when contracting, if the fetal head is compressing means as a fetal bradycardia. So early deceleration, but late deceleration is seen in fetal distress. Understood? Fetal distress, it is bad. And for variable deceleration, it is seen in umbilical cord compression. So umbilical cord is compressing, is always sometimes is compressing, is not associated with uterine contraction. Okay, that's it. First head compression, late deceleration is what fetal distress. Then for variable umbilical cord. For sinusoidal pattern, fetal anemia or hypoxia. Okay. 35 minutes. We can do one question. Okay. A priming gravid at 41 weeks of gestation was induced for postnatal and was put on CTG monitoring in active labor. She has been getting adequate contractions and her CTG trace is shown below. It is okay. And on PV examination, she is found to be 6 cm diameter, fully effaced and head at 0 station with bulging membranes. What is the next step? reactive honesty. And she is found to be 6 cm dilated. Head is also 0 stage.